All right, good morning. Well, after direct patient care, teaching the young or teaching students is the next most important thing. So we give you extra time. We have some students here today, right? Yeah. You guys went out and ripped up the town last night, I hope. I had a great dinner. I went to the Eagle's Nest, saw the whole, it was very touristy, I guess. It's an honor to be back here today. I thank Mohammed, thank Matt, thank Luis for an outstanding conference. Welcome to all the people online. Please do give us feedback for the online participants. Let us know how the sound quality and whether or not you can see enough of my face. I'm going to talk today about when to start, when to stop. Your success of an ECMO program is directly dependent on the quality of your patient selection. And that is one of the hardest things to do. Every institution has their own algorithm, their own criteria, and then we proceed to go ahead and not violate them, but it's a guide. Well, I guess we violate. We don't honor our own criteria on multiple occasions. Sometimes we're right, sometimes we're wrong. I have no disclosures. So every provider has their own private graveyard. We walk through it late at night, and the voices of our patients who've passed rise up and become some of our best professors. I'm not trying to be morbid, but this is reality, and it's something that we have to deal with in this profession and when we're dealing with life and death matters. We can use that as an opportunity for learning, but it really is, it's very easy to get up here and talk about our success stories. I want to always get up and talk about, to frame it in reality, that there is a dark side or a challenging side. I want to talk about Sarah. It was a Friday night. Like I said, it always happens on a Friday. And I got called by the pediatric ECMO director from another institution who had a friend who was, we have a pediatric ECMO program in my institution. It was much smaller. And they said, can you go over, there's a 16-year-old who's dying, and we want you to go over there and talk them out of going on ECMO. And I said, you're asking me to do that? I'm the wrong person. I love ECMO. I believe in it. And said, well, she doesn't have any platelets. Her liver's down. She has germ cell cancer. It's spread to her brain. She's had this multiple bone marrow stem cell transplants. She doesn't have an immune system, and she's been on high ventilator settings for 2 weeks. Currently, she's paralyzed, completely sedated, and the family's asking about ECMO. Can you go over and talk about the complications of ECMO? And so I said, okay, all right. So that should be easy. I'll go over and I'll talk about it. So I went in, and I guess the family had already asked the pediatric critical care team and the pediatric ECMO physician about ECMO, and they had said she's not a candidate. I walk into the room. She's 16, healthy 16-year-old. At the time, one of my sons was 16, so it was sort of close to home. She was also a soccer player. My son was a soccer player. I didn't tell them that at the time. So I started talking about all the side effects of ECMO. Bleeding, she could bleed into her brain. She could have infection. She could have air emboli. She could have clots. She could have organ failure. And it really isn't, I'm not sure. I didn't say it is. I said, I'm not sure that ECMO would be a good modality for her. And so I thought I was in the clear. I did my favor for the pediatric team. And then her father stands up, and he was like 6'6", big guy. He stands up in the back of the room, and he said, what would you do if it was your son? And I took a step back, and there's that thing, well, what am I going to say? You know, you hear different things in ethics about what you do when they talk about family. And I said, well, I'm going to tell you the truth, but I'm an ECMO physician, so that's going to color my answer. But I would absolutely put my son on ECMO in a second. I would not hesitate. That's my opinion. Will he survive? I don't know. I don't know if he's going to survive, but what I do know is if I put him on ECMO, I will have some time, at least a month or so. I can wake him up and talk to him. And he can say goodbye to his mother, he can say goodbye to his brother, I can talk to him. I'll be able to spend some time with him whether or not he survives. So that's why I would absolutely put him on ECMO and give him a chance. So the pediatric team was like turning red in the face, getting really upset. And then I called the surgeon and I said, well, let's get another opinion. We'll call a cardiac surgeon who's the surgical director of our ECMO program. And he, in true to form, absolutely agreed with me to give her a try. And we had one caveat. We said, well, if she goes on to ECMO, she's been sick for 2 weeks, she's got really sick lungs now, you need to give her time. I don't know why I said I would at least give her 6 weeks before I made a determination if she's getting better or not. That's a long time, but that gives you time to wake her up, get her moving around. So we ended up putting her on ECMO, and we woke her up. She was awake and interactive in about 2 weeks. We had her in a Craig bed. What's the name of the bed that's out in the lobby? I guess he's not here. There's another stand-up bed. Total lift bed. Okay, I want to give you credit for being here. Total lift bed. So, but she was up moving around. We had music on in the room. She had half-naked pictures of men in shirts, without shirts, teenage girl thing in her hospital room. I remember doing a bronchoscopy on her, looking up, and there was this guy without, you know, in his underpants on the wall. It felt a little weird. You know, was that the right thing to do? When to start? You know, I don't know. I don't know. I can tell you she obviously did not survive. I can tell you that it was very difficult for it almost took out our program because we had some of our attendings saying that this was crazy, we shouldn't do it, we're torturing her. Those attendings don't work in the CVICU anymore. But, you know, that was their opinion. That's fine. We had some nurses that said this isn't fair. When she passed away after about six weeks, and it was at 6 weeks, that was just a weird coincidence, but the family, the amount of love that came out of that family was amazing. And her father, her mother, her sister, her brother, her boyfriend, all were very, very grateful for the time they had with her. Along the way, they'd bought a cat and they named it after one of the people on our ECMO team. So was that positive? I think so. I think so. Now we still go. They're out there doing fundraisers and speaking and kind of talking about, you know, is it palliative ECMO in this situation? We didn't expect her to survive. We just wanted her to have some time with her family. So there is a silver lining in there, but at the same time, it was a difficult situation. So we had to have like counseling for our team. Some of it was we were an adult, you know, cardiac ICU. People get better. You know, they leave after a couple days. You're not in there for months, and then if you're not used to dealing with teenagers, it's harder. Just to, I don't know if that's a happy story or not. It's not. It's not. So let's talk about selection. So I used to say there are 3 groups. Now, in the advent of COVID, I say there are 4 groups. So you have the lungs, the lung failure, that's VV. VA, veno-arterial, so that's you're in shock, and you're still in shock despite optimal management. ECPR, that's just crashing onto VA. You guys know that, but that's in its own category because you don't have time to get a history. You have maybe a minute. When they call us for an ECPR, and we get called after about, we're supposed to be 10 minutes. Now I have them call them at 5 minutes because it takes us about 5 minutes to get down to the cath lab or the ER. As we're going down, one of the ECMO team members is biopsying the chart. Another one is calling family, trying to get corroboration. You know, what they have renal failure, are they on oxygen at home? And then the fourth category now is COVID, because it was an unknown disease and it required so much resources. We really had to have stricter criteria, and we had to change the criteria. They were dynamic based on our resources. If we had beds, we could be a little bit more open. When we got down to our last bed, we were very strict. And we had to say no to people that we normally say yes to. And that was the great moral challenge of the COVID pandemic. I don't know how many 40 and 50-year-olds, people my age or younger, that we had to say no to. And we knew if we got a hold of them, we were at about a 70% survival rate for COVID. Now, we're a high volume. We had a lot of resources. It's not saying that we just had a lot of resources. But we had we had to say no to ECMO, and that patient was going to die. And then we got sued for it. Thankfully, I have big lawyers, and it didn't work out. But you know, what do you do? We need more ECMO beds, and that's education. That's students. We need more ECMO beds. If we had more ECMO beds, if we'd invested more money up front into more machines, more training, you know, it wasn't a lack of machines. I credit the industry. They came through. They got the Germans to make more stuff. Trying to increase German work hours, that's really hard. But we did. They made more machines. We didn't have the nurses. We didn't have the nurse. It was staff. Why do we have now? I don't know. So ECMO is for a reversible process. We know this. No known contraindications, reasonable expectation of recovery, and they're a device or transplant candidate. You don't always know that up front. And the heart failure guys will say, oh, yeah, they're a bad candidate. And like, wait a minute, the BMI is 70. Oh, yeah, Duke puts them in. Well, we don't have a surgeon that's going to put a VAD in someone with a BMI of 70. But they'll tell you stuff. You got to be careful. So for VV, they need to fail lung protective surgery. That's the standard of care. There is very strong evidence. Low volumes, low pressure, prone positioning, flip them over. Even if they don't want to, if the team doesn't want to, go in there and say you'll flip them over yourself. You guys know how to flip people over. You want a reversible process and or be a lung transplant candidate. It's better if they've already been vetted or been evaluated for a lung transplant. And then the P to F ratio, here's where your PaO2 is extremely valuable, less than 100. I think ELSO does 80. We start thinking about it when they're less than 150. Oxygen, low saturation, low PaO2. And then for ventilatory failure, your pH less than 7.2, CO2 greater than 65, and then large air leaks. Earlier is better. And then if they've got, so these are your standard contraindications. You can't get the cannulas in. They have severe end organ dysfunction, you know, cancer. We did put a guy with stage 4 metastatic lung cancer on with the caveat. We said, we'll give you a week, and then we're stopping. But he wanted to get to his grandson's graduation. And he did. And he was, I had to explain that to the administrators because he was 92 years old. And we put him on BV ECMO, and he had stage 4 lung cancer. But, you know, it actually worked out. And we put very strictly in the, you know, we said we're going to go for a week and then we'll stop because the administration doesn't want you holding up a bed because they can run, you know, 4 cabbages through that or TAVRs. Is there any administrators here? I'm going to get in trouble. VA ECMO, shock and inadequate perfusion, so low blood pressure, low cardiac index, despite adequate volume and despite inotropes and vasopressors. These are your standard therapies. So this is just basic reminder, low systolic, MAP low, lactate 4 and rising. Cardiac index less than 2, your PAPI less than 1.8. That's an indication of right heart failure, the pulmonary artery. And then pulsatility index and your cardiac power output. Strong now in the shock literature. A lot of the intensivists don't use it. Not all of our surgeons use it, but it's been vetted now and it works, the cardiac power index. So when you're in SCI, so this is the Society for Cardiovascular Angiography and Intervention. So this is your interventional cardiologists. They have a shock classification. C is classic, D is deteriorating. When you go from a stage C to D, so when you start to have hypoperfusion, that's when we jump in and start with MCS or ECMO, because your mortality is going to increase to 40% when you go to D. So pretty much when signs of hypoperfusion present, they're on pressors, the lactate's rising, their kidneys are going down, their head isn't right, their liver's wrong, then you consider it. This is just a picture of it. This was back from 2019. It has caught on in the shock literature. Not everybody uses it, but it's pretty easy. It's just C is classic, D deteriorating, and then you see the significant increase in survival between C and D. So here's a little cartoon. So you're in shock, so you have low blood pressure. Your lungs are not sick. You've got a balloon pump, Impella, or Centromag, among other things, not advocating for any one. So some type of support device, a mechanical circulatory support. You're in shock and your lungs are sick. General guideline, PEEP greater than 10, FiO2 greater than 50%, P-to-F ratio less than 200. So this is like moderate ARDS now. They switched it now. Your partial pressure of oxygen divided by the inhaled, what you're giving them through the vent. If it's less than 200, that's moderate ARDS. Less than 300 is mild. So here's where you think about ECMO. And you can do ECMO with the Centromag. You can do ECMO with other pumps as well. ECPR, the fastest growing area in kind of adult critical care. This is taken off. The ARREST trial was very strong, was stopped early because there was such a strong signal. Now what they did is very hard to reproduce. They had a healthcare system in Minnesota that had been training for years. So all the ERs knew, the ambulances knew, they had cannulators trained, ECMO physicians trained that knew how to select well, and then they put them on right away, put them on ECMO right away, and they showed a tremendous survival increase. Witnessed arrest, so no flow, less than 5 minutes. You can get them on ECMO within 60 minutes. Reasonable chance of recovery, that's kind of subjective. No chronic organ failure, pH greater than 7. You've all heard pH less than 7, go to heaven. Lactate less than 20. You know, Mayo uses 16. Other places use different values. If you had to pick one variable that's the most predictive of not necessarily survival, when we're talking about it, we're talking about a good neurologic outcome. We're talking about independent function. That's what we want, because that's what people want. You don't want to survive and be in a bed in a neuro rehab flipping channels. Maybe, but I don't want to. So, and then age less than 75 or a prior excellent functional status. Oh, they're 98, but they're a robust 98. He's walking around. ECPR it's, if we have a heart attack right now and you go to the ER, what's our survival? It's like 8%. And that's survival to good neurologic outcome. It's 8%. If you have an experienced ECMO team and you can get them on within an hour, that goes up to 30, 35%. That right there, that jump from 8 to 30%, that's hundreds of thousands of lives saved. And these patients, they're going to go back into the workforce and work. So they're going to contribute. It's not, I guess, they're going to play with their kids first. They're going to go back to their families. You can tell I'm a workaholic because I'm like, oh, they're going to go back to work. But they're going to go back and contribute to the economy and pay off the money we spent saving them. So there's an ROI here that's bigger than just one hospital system. This is slower to come on. Germany has now embraced ECPR as the standard of care for cardiac arrest. They had. So that's a big deal. They're ahead of us. As you know, devices get approved earlier in Europe. All right, contraindications for VA. So you guys know this: severe AR, aneurysm, dissection. You can do LAVA. There's special forms of ECMO you can do if you've got bad AR, but in general, Obviously, a head bleed, contraindication. That being said, our trauma patients that had small traumatic intracerebral hemorrhages, we would pause. We'd do a CT in 12 hours. If the hemorrhage isn't getting bigger, we'd put them on ECMO anyway. These are young guys with small bleeds. Or, irreversible cardiac disease is not transplantable. COVID, we talked about criteria narrows as capacity declines, and that's your ECMO capacity. It's like combat medicine. So you have limited resources, you select those more likely to survive so you can put them back into the fight. Hard to do, but you have to do it. VV, as we learned about COVID, we counted high flow and BiPAP as vent days, because the patients that went on after 3 or 4 days of high flow had much lower survival. You got to get them early. If they had pneumomediastinum, even if they're young, those people didn't survive. The heavier people, now for normal VV, the BMI is not a contraindication. They do just as well as your normal BMI in normal VV, but we're COVID VV ECMO because they just didn't do as well. Obviously, chronic end organ dysfunction. We had to say no to some people that had bad diabetes. And when would we do that? Diabetes is whatever. Everybody has diabetes. But we had to discriminate just to make it fair, I guess. VA, case by case. ECPR, everybody said we're not going to do it. 20-year-old goes down in front of you and they've got COVID, you give it a try. As you know, the COVID outcomes got worse. Whether that was as viruses evolve or mutate, usually they get less virulent. Something happened with one of the strains of COVID where it was more virulent, or it was getting a different patient population, or our resources had diminished, because in the beginning, remember, that's all we were doing. So all of our best cardiac nurses were taking care of our ECMO patients because we weren't doing surgery. Then we started doing surgery, and now your resources are thinned. And in fairness, you need to take care of everybody. So some of it was resource allocation. All right, let's talk about, this guy's name is Mike. He's 22. He had a motor vehicle collision 16 days ago. He had severe DAI, diffuse axonal injury, no neuro exam since admission. His GCS is 3. He does have reactive pupils and a gag. So he broke like every bone in his body. Multiple long bone fractures, pulmonary injury. He's on moderate vent settings for 14 days. He's in the trauma ICU. So they just put them down and fill him up with salt water, or LR. So the last 2 days he gets severe ARDS. He has large bilateral PEs, and he's got MDR Enterobacter pneumonia. We called to consider VV ECMO. So he's 12 liters positive. He's been on ridiculous settings now for a couple days. He's 14 days in, and now he's in multi-organ failure, and we have no neuro exam. What do you do? Say no? So I still remember this call, and so I wasn't sure. He's outside of all sorts of guidelines. But he's 22, and I came up in the Army, so I know a little bit about diffuse axonal injury, and I know there's time sometimes. But it was not looking good. I called a friend, so you're not sure what to do, make it a collaborative. I called one of my friends at the institution I was working in. He said, well, whatever you want, you're on call, I don't know. So then I called one of my mentors in Germany and asked his advice. So it's really hard to prognosticate with DAIs. If you have TBI and you have low blood pressure and hypoxia, your chance of a good neurologic outcome dramatically is reduced, decreases. And so that's been shown in multiple studies. So we went ahead and went for it, put him on, and when I told the family, I said, well, we can fix his lungs. I don't know about his brain, but we're going to give him time on ECMO. We'll get him through this acute lung process. The PEs can be fixed. The pneumonia can be fixed. I'm not sure about his head. So how long do you go? 6 weeks, he opens his eyes. but he's doing nothing, off of all sedation for weeks. And all he's doing is opening his eyes. Different opinion. Trauma says it's time to go palliative care and donate. I mean, that's what they said. No judgment. Neurology says he's never going to wake up. Our best neurocritical care doctor, who at the time, I said, well, call Laith, he's really optimistic. And he was. And neuro says stop, trauma says stop. What do you do? Who knows? Do we know? So that's 9 months later. You guys gamers, there's a new version of Halo, right? He was part of that. Now, he wasn't the main designer, but now he's helping design. He was part of, so this was a few years ago. He's a gamer, he's a computer expert, and he was part of one of the people who worked on the new version of Halo for all of you gamers out there. He has vision problems, he has some coordination problems, but in 3 months, he totally woke up, and he got better. You know, what I told the family is, I don't know, but I've seen people get better. He's got a young brain, these are fixable problems, let's give him time. You know, trauma surgeon said, well, we're done, forget about it. They were really mad because they thought it was their patient. You know, trauma, we're the captains, and when he gets to ECMO, then in the CVICU, no, the CVICU team runs it. So you have different ECMO specialists, different physicians. We don't know. What we do know, the brain has regenerative powers much greater than we expected. We do know that. So what I look for, and it's different, I look for reasons to continue. So, okay, he opened his eyes at 6 weeks. At 7 weeks, he was opening his eyes with greater intensity. Now, they said I was crazy. You're being a crazed op, but he did. Initially, he was opening his eyes like partially, and now he's opening his eyes all the way. That's improvement. That's improvement. So you just want to give him time. You need to give them time. And that's hard to do because if the team thinks that he's a hopeless cause, if your bedside nurses, if your bedside perfusionists, if your bedside ECMO specialists, bedside doctors, if they think it's hopeless, there's been studies done, they don't do well. So you've got to work, obviously, if you have optimism in yourself, you have to also spread that around. And that's sometimes hard to do when people are telling you it's crazy. So we have a 36-year-old. This is Jennifer, ballet dancer, massive effexor overdose, refractory seizures, acute liver failure, renal failure. But it was just 24 hours ago. ECMO called, PA arrest 65 minutes, Rosh times 3, shock, CPR, 65 minutes. And the CT scan shows early uncal herniation. Pupils fixed and dilated as per neurocritical care right before the arrest. pH 6.8, lactate 7. Health prior to overdose was excellent. So she's under our pH cutoff. She's over our time cutoff. She has signs of herniation. We're going to cannulate. Dr. Bogar has, somebody's reading the CT report and saying herniation, and then she stops. And I was like, no, it's early. Let's go for it. This was just 24 hours, and it was an in-hospital arrest. You know, give her some time, give her a chance. Is it worth it? You know, your ECMO decision, here's my, as you can see, I haven't lived on the ocean very often, but we were renting when I was living in Hawaii. But this was a tough decision. You know, we were doing CPR, you're cannulating, putting her on VA ECMO. Some people are saying it's hopeless, she's outside of the guidelines, and we're saying let's give her a chance. And then you have to answer for that afterwards because they're taking up a lot of resources. So we do 25 femoral venous drain, 15 French return, distal perfusion cannula. Her EEG is flat for 2 days, off of everything. Pupils remain fixed and dilated, no response to deep pain, no gag, no corneals, off all sedation. Basically like has an exam of someone who's brain dead. But wait, she has liver and renal failure, and it was an overdose. And she was seizing for a long time. So too early to call, too early. Neurology didn't say that, other people didn't say that, but as ECMO physicians, we knew that it was too early. So 2 days in, ECMO's flow is maxed, sweep is up. She's still, now we have blood pressure dropping, and we're going up on our norepi, we're turning up our epi, we're doing CRRT. What do you guys want to do here? 2 days in, the family start, it's on the next slide, but the family starts saying, want to withdraw. Like her husband said, we should withdraw because they talked to neurology. And then her father said we should withdraw. That's a tough one. And she's getting worse. All right, so we do a chest x-ray and an echo. Family says she's never going to wake up. Family wants to withdraw. Neurology says she's never waking up. Prolonged downtime. Well, was it right to start? I mean, I guess no one's going to say no, right? Should we stop? You're not wrong. We had some people on the ECMO team said, look, this one, if we stop early, get palliative care involved, you get out in front of it. If you go long on her and she doesn't do well, she's outside of our guidelines. We're a new ECPR program. You're going to take the heat and it's going to slow down, decrease our ability to put other people on. And that was one of our senior, well, he was older, I guess, but one of the ECMO physicians. So we don't know the right answer. We don't know the right answer. But we do know she was cooled and she had multi-organ failure. So you can say we need to give her some more time. And she has a reason to have flat EEGs. There's a reason to flat. And then the pupillometer, who like some people make fun of, the pupillometer showed she was at zero, like no reactivity, showed a tiny, this is on day 3 now, a little bit of reactivity. So bang, there we go, she's getting better. I'm serious. You have to have that subjective evidence. She's getting better, give her some time. But then we're in trouble now because her pressure is dropping, her LV's distended, is not contracting, the aortic valve is not opening, septal bowing. There was a nice graphic about this the other day. EF is like 10%, worsening gas exchange, increasing pressors. Here's her x-ray, very wet, AV closed, her pulsatility, she's not pulsatile anymore. EEG's flatline. What are we going to do? So does she need venting? You guys always know this already. So what's the best way to do it? No vent? It's actually where I trained in Germany, they didn't vent. They cranked up the PEEP, they cranked up the CRT to pull fluid off, and they accepted lower blood pressures. Now their survival wasn't great. You want a balloon pump? Could work, yes, people do. It's actually the most common way that people have vented. We don't use it, big places don't use it. Atrial septostomy works. Impella, a biomed reps here. This is the most common, at least in a lot of the bigger places, Impella. So picture, you guys know this, competing blood flows. That's why. And it just makes your heart failure worse. And it makes your lung failure worse. So we put in an Impella, and it really helped her hemodynamics. You guys know Impellas. I wanted to show a few pictures of Impella. It does work, but it causes bleeding, it causes hemolysis, it's another arterial stick, and you know what I have to say is what we find, and they say that it causes bleeding, head bleeds, we had this problem. And when we looked at it, we looked at the autopsy data. It actually, what was the underlying pathophysiology? It wasn't a head bleed. The head bleed came after the embolic event. So what happens? So they get the Impella in, then they're on heparin, they have heparin purge, they go down to the cath lab, they're not thinking, they're like, oh, let's just bolus them with 15,000 of heparin, and they're already on ECMO, they're already anticoagulated, but they're just the reflex. So they start bleeding. Okay, start bleeding, then they stop the heparin. Stop it, and keep it stopped. And when the heparin is stopped, then that thing, you've got embolic events, and the emboli go to the brain, and they have strokes that you don't always see because the patient is sedated. And then you turn the heparin back on, and then they bleed around the stroke. We saw 5 cases like that. So what they were saying was, oh, it was a head bleed. Yes, it was, but the underlying pathophysiology was actually, in those cases, now I'm not making any general, in those cases it was a embolic ischemic event. So it's a different perspective, because it just didn't make sense, right? Head bleeds don't happen they happen in flu patients maybe, but not in, not to this degree. All right, so this is a 3.5 centimeters from the aortic valve, our impella's in. Here is our, this is an we put a little stent in this atrial septum, and it does help vent the LV. Not as active as the impella, but it doesn't require additional arterial stick, and it doesn't require additional anticoagulation. So this was Jennifer, this was her room. She's got everything in there, ECMO, CRRT, an impella, an EEG, the vent. 9 days she comes off ECMO. She got better. 7 with impella, liver and kidneys recover, right BKA, excellent neurologic recovery. It's amazing. These suicidal people are always really smart. I don't know. They really are. Because I'm like, I need to talk to her, because everybody's like, oh, her brain is mush. You know, as a young kid, we cooled her, we got on her right away, we did good CPR. It was all, that organ failure was all acute. So absolutely, I would do all this again the same way. We might have been able to handle some of the consultants a little bit better in terms of, that was when we learned to warn the family. You listen to the ECMO team, we're in charge of her care, we take care of ECMO patients, that's what we do for a living. The neurology and trauma, they're not used to it, they're excellent doctors, but they don't take care of ECMO patients. This is a different physiology. We're changing how they normally get oxygen and get blood. So you need to listen to us and don't worry about the trauma surgeon talking about trach peg, palliative care. So she went on to be an instructor in her ballet school. We gave her lipids, which wasn't done for the overdose. We gave her IV lipids, and what do you think that did to the circuit? It stopped, yeah. But we had a backup right there and ready, and we made sure that a perfusionist was on when we did it, because we knew we were going to have to do a really quick circuit change out. Maybe it helped, I don't know. How are we doing on time? Do we have a few minutes? Just a few minutes? All right. So this is Charlie, 2 months before. He's a healthy 28-year-old soldier. He's sleeping outside. We're in Afghanistan now. That's a forward base. He gets sick. He gets admitted to the floor for doxy. He has a transaminitis, low platelets. 2 days later, oxygen goes up. He gets Levaquin. It was an American bag of Levaquin. Bang, anaphylaxis. I've never seen this. It was crazy. We're on the ward. One of the nurses ran over because he gets red, and they're like, something's wrong with him. And he said, oh, I'm drowning. So we tubed him right away, sent him to the ICU. I guess it's been reported, we use Levaquin all the time. So he's in the ICU in trouble. Severe ARDS, acidosis, shock. It's both distributive and cardiac. EF is down. He's maxed out on pressors. Liver failure is crazy. Shock liver. He has renal failure. PEEP is 22. These were damaging settings. This was necessary to keep his SATs above 70. This is our sophisticated charting mechanism in Afghanistan. But here's the thing. His pH was below 7 for 12 hours. So, okay, we can get his body back, but are we getting his brain back? And at the time, this was a long time ago, but we didn't know. And I lost sleep over this, because this guy, turns out his dad was a general. And it was, I was the senior American at the time, and I'm in a British hospital run by the British, and they say, we don't do ECMO. You're not credentialed for ECMO. And I said, of course I am. No, not in our system. I said, well, I have it, and I was credentialed obviously in the American system. So is he a candidate, yes or no? So they said, no, you can't do ECMO. I said, well, let me call his father, because this guy's going to die. This is his only chance. We have a transport team in Germany. They can get here in 12 hours. And I sent our best negotiator. I said, go talk to that commander and just don't let him out of his office. Keep talking to him. I don't care what it is. We're calling the ECMO team. I don't care if we get in trouble. This kid's going to die. And I called the guy's father, who's a general, and I told him the truth. I said, this is his one chance. I don't know about his brain, but we can get down here. We can put him on ECMO, but then he's going to have to go to Germany. We're not going to take him to Britain because they're not used to this. This was a while ago. They are now. But the British military hospital hadn't done a lot of ECMO. So we have a good relationship with Regensburg. They do hundreds of cases like this. He needs to go there. And the British are anybody from London here? No? They still think of us as like the deranged adolescent. You know, they kind of look down on the Americans. They really do. They have that British hubris. And I mean, I was like, my family came over from London a long time ago. We're from the same, you know. Anyway, is he a good candidate? Absolutely. This is all acute. It's all acute. Now, what kind? What kind? Some people, you're not wrong to say VA, but we're down in Afghanistan, and this is all a respiratory problem. Once you fix his acidosis, as soon as we put him on ECMO, his pressors came way down, and he was just on a little bit of norepi. So what do we want to do? We'll bust through this. So the point here was VV is you can always convert to VA. It's very easy. As soon as we fixed his gas exchange, his pressure got better. Is he a candidate? I'm going to bust through here. Same thing. The senior ICU docs from England said he's going to die. Don't do it. And they were scared because if we saved him and he ends up being a vegetable, the commander of our hospital has to answer to his father, who's a British general. So I get it. I get it. But I said, look, you can put it all on us. When there was a sick patient, the Americans took over anyway, just because, I don't know, this is what happened. My battery's low. All right, we'll hurry up. Battery's low. Here he is. So how did he do? What's his outcome? What do you think? So he's going to survive, but how about his disability? So he did survive with a mild disability that resolved over time. There he is in, what about his brain? What was the infection? Q fever. Hemodialysis, it's a 1% of Q fevers will have this, get really bad. So this is him 10 months later, and he's hiking, oh man, okay. Well, there you go, that's okay. There's a picture of him. The point of that thing is they bought a dog and they named him ECMO. Which, and he's like, listen, this is the best kit ever. I want you to, now he had headaches and he had some pain. He was a lieutenant back there. Now he's like a lieutenant colonel in the British military, and he's a great ECMO advocate. I thank you for your time. The point here is we have our guidelines. Have it be multidisciplinary. Get your most experienced people. Talk to your ECMO specialists, your nurses, and your physicians. Talk to everybody on the team, because you're going to get different perspectives, and they actually know more than you think, more than a lot of doctors are like, well, but you need to talk to the whole team when you're making decisions that are like this. And then you have your guidelines, but then don't be afraid to have your guidelines be flexible.